So thank you. I feel privileged to be here today, and I want to thank the ESPID Society for this exciting moment. These are my disclosures. So I grew up at Schneider Children's, a pediatric center in Israel, and pediatrics was an easy choice for me. I mean, children have always symbolized an infusion of hope and optimism. During my residency, my intense exposure to the area of ID among immunocompromised patients led me to choose this path as my future. And so my research started off from everyday questions I encountered during our rounds, and the answers, I hope, helped improve our patient care. So it's a bi-directional relationship. The first question that really bugged me had to do with our solid organ transplant recipients with the most common virus, CMV. What's the right dose of valganciclovir for CMV prophylaxis? I mean, several dosing algorithms have been suggested, according to weight, as in the treatment of congenital CMV, according to body surface area, or a combination of BSA and GFR, as in the manufacturer's recommended regimen. However, this regimen was problematic, so it was not based on any pharmacokinetic data in children. And indeed, the FDA issued a safety alert warning from excessive dosage in young children. So we were reluctant to use this dosing and went on to conduct a prospective study evaluating our center's weight-based dosing regimen, focusing on the pharmacokinetic indices of valganciclovir. Our results showed a clear relationship between exposure and BSA, and with age. Moreover, it showed that our weight-based dosing regimen was associated with low AUCs, low exposure, yet with satisfactory clinical efficacy. However, the study was limited by its small size and lack of long-term follow-up. So we went on into a larger cohort with long-term follow-up. And when we compared our results to those achieved using the manufacturer regimen, we saw there was no difference in the incidence of CMV in the first year post-transplantation. Where did we see a difference? In the safety profile. Using our regimen, there were significantly less adverse effects, less leukopenia, and less neutropenia. So based on these results, we feel confident in using our regimen, and I do hope that these data will be taken account by Transplantation Society. Moving on to a different type of infection among immunocompromised patients, namely fungal infections. A question I thought was, among the liver transplant recipients, who should receive antifungal prophylaxis? And by investigating a large cohort of liver transplant recipients over a 10-year period, we developed a predictive model for invasive fungal infection. The model did pretty well with an AUC of 0.9 and enables targeted instead of universal prophylaxis. What can we offer our patients when all else fails? In our center, we encountered some severe mucor infections, and these two studies describe our experience using novel antifungals, posaconazole more than 10 years ago, and isavuconazole. And this fascinating lab work with Professor Ben-Ami tried to figure out the reason why some patients infected with Candida auris fail to respond to echinocandins. And as you can see here in this 1-1 staining, when those patients infected with Candida auris are treated with caswifungin, only the peripherally positioned yeast cells stain green, meaning they're non-viable, but the center remains orange, meaning it's viable. So these persister cells may be the explanation for this phenomena. This research was the basis for this narrative review, discussing the concern for the global emergence of Candida auris, even in the pediatric population. So we talked about the immunocompromised host, but let's focus a second on just the host. The host response to infections can help us differentiate a virus from a bacteria. But imagine you didn't have to draw any blood. Imagine you only had to take a non-sterile urine sample. So in order to answer the question if it's a virus or bacteria, you can use the host protein signature. I mean, in this prospective study, it did much better than other prediction rules, such as the lab score, and other biomarkers like the HNL. Most importantly, it had great potential in reducing antibiotic overuse, but close to 90% by identifying those viral patients. And this prospective study is a proof of concept that urine biomarkers can help us diagnose UTI, even in very young children. And following these results, we filed for a patent for urine biomarkers to the FDA just last year. Immune-compromised, immune-competent, antimicrobial resistance is always an issue. So we can promote the use of narrow-spectrum antibiotics, or when we encounter a resistant pathogen, we can talk about non-antibiotic alternatives. And the next two studies try to do that. If it's with odontogenic abscess, where we showed that penicillin was at least as good as amoxicillin clavulanate, or in difficult-to-treat line infections, where ethnologue strategies as adjunctive treatment help increase our catheter salvage rates with very low adverse events, including patients with mycobacteria infections, Candida species, and even some Staph aureus infections. COVID obviously brought some interesting thoughts, like this last burning question: what's the magic number? Is there a correlate of protection of cord blood antibodies for the protection of infants in the first months of life? And this prospective study, just accepted to CMI, says yes. A cord blood titer of a birth of around 11,000 can predict infant protection from COVID in the first 6 months of life. So many of my questions were managed to be answered, but going back to where we started, many questions still remain unanswered. When my youngest daughter grows up, she wants to be a doctor and a singer. When I grow up, I want to move from small data to big data, to keep answering those questions, to collaborate with researchers in this room whom I deeply appreciate, in order to improve the care of immunocompromised children internationally. I want to thank my inspiring mentors, my sharp-minded students and collaborators, and again, the ESPID Society for this honorable award. As an engaged learner, I will try my best to continue to grow and to do research that matters. Thank you.